this is about study types. So if you were expecting something else, too bad. So we're going to talk about study types. This is part of the series, Scholarly Snippets, to help you advance your research skills and support your scholarly activities. After this little lecture here, you will be able to recognize case series, cross-sectional, case control, and cohort observational studies. And you will also be able to describe the difference between bias, confounding, and effect modification and random error. So that's exciting stuff. If you have any questions, you can pop them in the chat. I've got the chat where I can see it, but I can't see the pictures because seeing myself is distracting. All right. So you can divide studies basically into two different categories. You have observational studies and experimental studies. And this little lecture is going to be about observational studies. And these are the ones, these are generally considered epidemiological studies, where it's just an observational thing. The researcher simply observes the exposure and disease status of the study participants. Experimental is where you have like a controlled trial, clinical trial, community trial, something like that, where you've got a very controlled process, and then you track these individuals or communities over time. So the first question you have to ask is there an intervention? If the answer is yes, then you have an experimental study. If the answer is no, then you have an observational study. So that's the very first question you ask. Is there an intervention? Then, once you decide there's not, and that you've got some observational studies to look at, the next question you ask is there a comparison? If there is a comparison group, then you have a case control or cohort study. If there is no comparison group, then what you've got is a case series or cross-sectional study. And we're going to look at each one of these. Okay. Now, a case series is exactly what it sounds like. It's just a series of case reports. They're purely descriptive. They often describe something new with kind of an unclear cause. There is no control group, and they're considered the lowest level of evidence. But they are also, I always don't like for people to kind of beat up on case studies and case series, because this is the first line of evidence. This is where we see new and emerging things, right? And some of the most famous case series and case studies are of HIV. In 79 and 81, I believe, two different physicians wrote a case report on on the symptoms of HIV and AIDS, right? And so those were the very first descriptions of AIDS. Okay, but they don't address causality, and really they don't provide prevalent stats. It's just a purely descriptive thing. Now, next we have cross-sectional studies. Okay, and this is where patients are studied because they remember you got a group you want to study, right? And like, so our medical students, our first years could be a group. And what we're going to do is we're going to survey them at a single point in time. Let's see if their stress goes up or down after a big anatomy exam, right? And so right after that exam, we're going to take the snapshot in time, and that's what we got, period, right? So the frequency of disease and risk factors are identified. And the main outcome of this study type is prevalence. So you can't really determine relative risk or odds ratio. You're still not addressing causality, but they're easier and cheaper than other designs. The next one we have are the case control studies. And a case control study starts with disease and goes backwards in time looking for exposure. And that's kind of the key difference between a case study and a cohort study, is that a case study starts with disease. And so you compare a group with a disease to a group without the disease. Okay, both groups, the ones with a disease and those without, must have both unexposed and exposed people in them. So the main outcome you're looking for here is an odds ratio. And so this is where you get You know, if you've been exposed to, if you have X disease, then odds are you were exposed to Y. Okay, and the patients are identified by disease or no disease. Okay, it looks for disease, then exposure. And this one's better for rare diseases. And that's because if it's rare, then it's a whole lot easier to find people that have it than to have a cohort that you're going to follow in time to see if they get it, if that makes sense. And we can come back to that if we need to. Okay. Now, a cohort study generally examines a group over time. So this group is assembled because they share a common experience or exposure. And generally, you're looking for relative risk. You can calculate odds ratio in a cohort study, but I always want to see the relative. If it doesn't have relative risk, it's immediately going to give me Spider-Man tingly senses. I want to know why they did not calculate relative risk. Okay. Then you look for exposure, then disease, right? Exposure, then disease. So the main characteristics of the cohort study is that the study goes from exposure to disease. So case goes from disease to exposure, cohort exposure to disease. And they're mostly done prospectively. So that means we would get our cohort together, establish the baseline, and then follow them forward in time to see if they develop the outcome of interest. And of course, some of the most famous ones of these are the Framingham, I'm saying that right, heart study that's been going on for decades. There was a nurses health study that went on for a good bit of time. So they're just waiting to see if the person develops the outcome that they're interested in. These can take a lot of time and a lot of money. So that's one of the drawbacks of the cohort. Now here's where things start to get a little sketchy. All right, so got a little sketchiness going on here. You can also have a retrospective cohort study. Okay, so, but the design is the same, right? Because you're still starting with exposure. So in the prospective cohort study, you conceive it, design it, recruit subjects, do your baseline, do all of that before any of the subjects have developed any of the outcomes of interest. Okay, and then they're followed into the future. A retrospective study also groups subjects based on their exposure status to compare their incidence of disease. However, in this case, you know the outcome, you know it. And lots of historical retrospective cohort studies, you'll see those using like medical records or things like that. So don't get those confused. So just, right, we're going to recap these because these trip up our students all the time. So a retrospective cohort study is not the same thing as a case control study. And that's key, right? A retrospective cohort study compares the risk of developing a disease to known exposure factors. A case control study, they don't know what the exposure was, right? They've got people who are already sick, and now they're going to go back and look and see what maybe they were exposed to. So that's a key piece in the difference of a retrospective cohort and a case control study, right? So there's a known exposure here and an unknown exposure in the case control study. That's high yield. So now all together, a prospective cohort study takes people with a known exposure, follows them forward in time to see if they develop the disease of interest. A retrospective cohort takes people with a known exposure and a known disease, right? And case control takes people with a known disease and looks back for a common unknown exposure. Any questions about those? I know, right? It can be tricky. And a sneaky board, if you go on the medical board, item writers, they can really make some complicated things. So it's hard to tell. But if you focus on those words I have in that yellow there, then you will get that question right. All right, so here's kind of a slide just to kind of sum up when you're trying to figure out what kind of study to do, or what kind of study you're reading when it doesn't say, or you say, well, this doesn't sound like a cohort study, even though they say it is. The things you need to look for are, how are the patients identified, right? Are they identified by their exposure or their disease state or something else, right? What number can be determined from the study? And remember, we got cross-sectional for prevalence. We want to see a relative risk in the cohort studies, and we want to see an odds ratio for the case control. All right, and then the time period. Is there no time period? It's just a snapshot in time, or are they looking backwards, or are they looking forwards? So those are the questions that kind of a nice little cheat sheet there of what to ask yourself when either you're designing a study or trying to figure out what a study is. So I just want to take a little bit of things. These things get complicated too, because we talk about the things that can go wrong in a study, right? And so random error happens all the time because, people are messy. People don't do what you expect them to do. They don't do what they're supposed to do. And so sometimes you get that little, it's just chance. It's nothing you did, nothing. It's just life. It just happens. So it's an uncontrollable force that just seems to, mess up your results. Okay. So just random weird stuff. Like you're going to take the MBTI and you wake up in a really bad mood, right? And for whatever reason, then your MBTI might be a little off from your normal. Now, bias is a little bit different. Bias is a systematic error in the design, conduct, or analysis of a study, right? And when you have that in there, it can make the estimate of the exposure effect either less or more of a risk of disease. And I've just got a couple down here by example. Sample bias, these two right here get confused a lot because you have sample bias and then there's like selection bias is the broader term, and sample bias is under selection bias. It's kind of weird. So, but you got sample bias when you're using participants who aren't representative of the overall population, right? So if I wanted to study medical students, but my survey accidentally got distributed to nursing students, then I got the wrong sample. Selection bias is where you have a non-random assignment of participants. You want to see a random assignment of participants to avoid all kinds of bias. And then one of my favorite biases to talk about is Berkson bias, because it's a convenience sample. And the example I got here for Berkson's is the hospital patients, because if you use a sample of hospital patients, that's not necessarily generalizable out to the whole population, right? Hospitalized patients tend to be sicker, but they get to maybe more well taken care of than the general population because they're in the hospital. So that's a convenient sample, which is, you can have more than just hospital. Any convenient sample is something that you kind of got to watch for and notate if you're going to use that kind of sample in your research. And then recall bias, that's another good one, because if you're asking for people like in a case control study, like, were you exposed to X, or do you remember where you were? I don't know where I was yesterday, much less what I did, ever how many years ago. So recall bias is a real problem. So those are just some examples of bias. And now we get into the trickier stuff. So confounding is, it usually falls under bias, but it's not really a bias. It's a special thing, and it occurs when the observed association is due to 3 factors, right? And they're independently associated together. Okay, And so in my example over here, we're going to look at alcohol consumption on mortality, but alcohol is not the only thing that causes mortality. So you have to account for all these other variables: education, ethnicity, diet, smoking, age. All of those things depend on affect mortality too, right? So these are the confounding variables there in the orange. And so one thing, does anybody know how to control for this kind of stuff? Okay, so one of the ways you can control for this is just to make sure that you have this demographic information. So you're going to do a survey or a study on people, and you just don't want to have two boxes, right? You know, person one drinks this much, person two drinks this much. You want persons one, you want to know how much they drink, what their age is, what their sex is, what ethnicity they are, what's their education status, what's their diet. And then with statistics, you can pull all that out to see, oh, no worries, I'll get to that. You to see if, like, the older age group that drank a lot, did they, you know, you'll see that that age group may or may not, you know, the alcohol may or may not affect mortality. So you kind of stratify them into their groups so you can run the numbers. And that's why, you know, whenever you're doing a research project, you want to make sure that you get all that data, and you don't want, like, you don't want to collect the data based on, you know, age 20 to 30. You want to get their actual age, because on the back end in statistics, we can group those ages into 20 to 30. But if we found something and we wanted to undo that, we couldn't unless we got that granular of the data, if that makes sense. So, well, Bergson's bias is difficult to avoid in cross-sectional studies. So you're just talking about not you're just talking about a convenient sample in cross-sectional studies, and yeah, it's kind of.
I was wondering, since it was cross-sectional, it's kind of like it already has a convenience factor, I guess, because you're looking at a specific group. I'm just not familiar enough to know if that's something that is.
So it can be difficult to avoid, but if you're looking for prevalence in a particular population and that's what you're after. So like if we did, if our area of concern was medical students, then it's convenient that we work at a medical school, but we would still want to look at the medical students. So the convenience factor is kind of, it depends, and it depends on what the research question is, because if I want to do something to have people, let's see, what it was a good one, lifestyle changes. If I wanted somebody to improve their diet, so we're going to go out and we're going to try to get people to eat more healthy, and I survey people at a gym that you know, on their diet, it's likely that those folks, right, will already be eating better than the general population. So that would be a convenient sample, and you would want to know that. But if you were just doing, let's see, BMI of people that go to the gym, then you would have to go to the gym to get your sample. If that makes sense.
Yes.
Okay.
Thank you.
You're welcome. So when you have these confounding variables, it can make a distortion of the effect or of exposure on the disease by that third factor. You know, is it the smoking that's causing the people to die, or is it the alcohol consumption? That kind of thing. So it may cause an over or underestimate of the true effect. Another example is hormone replacement therapy and smoking on cardiovascular health in women, right? So is it the smoking, or is it the hormone replacement hormone replacement therapy. So when you're doing that study on women to see what's causing their cardiac issues, you need to know if they're on hormone replacement therapy. So having that data, you can kind of stratify, segregate those folks out and see if there's a difference. It doesn't mean they can't be in your study, but you need to know that they're on these other things that could be confounding the results. So that's a tricky one, and that one is very high yield. Now this one's even more special. Okay, effect modification. I think this is really a cool thing right here. So this occurs when the magnitude of the effect of the primary exposure on an outcome differs depending on a third variable. And you usually talk about some sort of modification in a biological phenomenon, right? In which the exposure has an impact on the disease state, on the risk factor and the disease state. So the best example of this that you see is smoking and exposure to asbestos are both risk factors for lung cancer. But non-smokers exposed to asbestos down here, they have their risk. Smokers have a risk of lung cancer, but shipyard workers who chronically inhaled asbestos fibers and also smoked had about a 64-fold increased risk of lung cancer right there. So if you smoked and worked in the shipyard, then those two things affected each other, right? So it's not even just additive in the case of smoking and asbestos. It's not just additive, it's actually multiplicative. It made it worse than if you just had one or the other, right, going on with one of the other exposures. This can be genetic too. You know, if you have a drug that works great in men, but doesn't work at all in women, that because something in the female is making that drug less effective, right? So there's some sort of effect modification going on. So that's a high yield topic too. I like to teach students about just the difference. And the key is in confounding, the third variable or the second variable doesn't affect the first variable, right? But in effect modification, that second thing acts on the first thing you're looking at, and it either makes it can make it better, but in the case of asbestos and smoking, it made it much, much worse. Okay. Are there any questions? So this is really just a little brief overview of the observational study types. Each one has strengths and differences. You can really get into the weeds with them and see which one, you know, if it takes a long time and you got a lot of people, it's going to take longer and cost more. And that's why you'll see, you know, people will start off with a cross-sectional study and say, oh, I found a thing. Well, let me do a case control study and see if I can find out more about this thing I've observed. And if it's something like a big deal, right, then, well, I'm going to do a cohort study on this. You hardly ever just start out with a cohort study. You start out with, you know, it builds on each other, which is kind of nice. It's interesting. Of course, you know, with COVID, that kind of changed everything. But in general, you will see the research build up from that least evidence down there, the bottom evidence on the EBM pyramid, and you'll move up. So you find a cohort study on smoking, you can get a case control thing on smoking, and then, you know, it's just fascinating to me. But if there are no questions, we have a little survey for folks to do. Let us know how we did. If you want more sessions on study design type things, we can do that. We can do studies on the different biostats. We mentioned relative risk and odds ratio, you know, how those work and why you use them, how you calculate them. That's interesting stuff. And then we have our next workshop right here is going to be on consumer health resources. That's a big one for librarians and for folks in public health. So I'm looking forward to that one. Yeah, so Dr. Jacobs, they record it, but I can send you the slides too.
Thank you. They're excellent. Nice job. Appreciate you clarifying a lot of that.
Yeah, it's just a matter of getting that words right and not getting confused on that. Remember that the case control, and I always tell the students to remember it. If you're in the hospital and you've got sick people, they're your cases. So if you got a case, if you see case there, that means they're already sick. So that's how I remember case control. And then cohort, you know, exposure. So you can remember exposure if you can remember your cases are sick. That's all I've got if there are no questions. I hope y'all enjoyed this snippet, lunchtime snippet, and will join us for the next one.